And the way that I introduced both of you, yes.
It should be working. Can you see it?
Yes, we can see.
Yes.
The problem is that when you okay, that's fine.
Now it's fine. Okay.
You need to.
Yes, okay.
And the presentation mode, okay?
Yeah, the presentation must be here. You must have it displayed now.
No, it's right. I can see
right,
COVID in progress. It's right.
Right.
But just the presentation mode instead of just showing the slides.
Yes, to the full screen mode.
So only my last question before we start. For me to introduce both of you, do I, to make a short introduction, assistant professor or associate professor from University of Barcelona?
That's fine, yeah.
Anything else, Paco?
Assistant professor. We have the same category now.
Assistant.
Yeah.
Dr. Figueras became a professor.
Yeah.
Professor.
The thing is that I went through a selection process, but because of the COVID crisis, it hasn't been published yet officially. So whatever you prefer, full professor or associate professor.
I was there.
Okay.
I was there. I am an eyewitness.
Okay, then you can introduce me as full professor.
Yes.
Okay, we are online now.
Professor, and we are the head of the service. I am the head of the service for gynecology, and he is the head of the service of maternal fetal medicine.
That's it.
Both from the same hospital.
Okay, we are online. Okay, we are just waiting Tatiani to put in the presentation mode.
Just let me ask you how can I mute my my microphone? Here, no. What is the option to mute?
Under your name.
Computer?
Just to click in below your name in the microphone symbol.
The is that I don't have a microphone symbol, but I have it's a camera one. Well, but I will remain quiet anyway. Okay, that's fine. That's fine. Okay, go. You can go ahead.
Good evening, everybody. Good evening in Brazil. Good evening in Spain. It's 7 p.m. here in São Paulo. It's midnight in Barcelona. First, I would like to thank our friends, Professor Francisco Carmona, that is associate professor from University of Barcelona and the head of the gynecology division in that university, and Professor Francisco Figueira, that is also the associate professor from the obstetrics and gynecology department at University of Barcelona, and also from the University of Barcelona and from this division. Can you hear me, João?
Yeah, I can.
In this debate here, in this discussion here, we are going to discuss. We want to have our friends sharing their experience in what is going on in the women's health in this crazy month that with the COVID-19 in Spain, and for us to learn with the experience with these two brilliant colleagues that are with us here. We have here João Ciufi, that works with us here at the Beneficência Portuguesa Hospital, that will make some comments with me afterwards. So I'd like to start with Professor Carmona, that will share his experience in the gynecology patients during this month in Spain. Thank you for your participation.
Thank you, Mauricio, and thank you for inviting us to this webinar. And for us, it's always a pleasure to be with you. Not in Sao Paulo now, but next time I hope it will be in Sao Paulo with some caipirinhas as the last time. Let me share my presentation with you. And now, do you see the presentation, Mauricio? Mauricio?
It's good, very good.
It's good. Okay. So my topic today, as you told before, is to explain our experience here in Spain with the COVID-19 pandemics. You know, this is the evolution in Spain of the curve of cases. It has been a crazy month. Spain is the country all over the world with the highest number of cases per. When you look at the day of the pandemic, when the day Cirurgia, the first day is the first day with 20 cases, and except New York, we are always at the head of the number of cases in Spain. Unfortunately, we are also the country with the highest number of mortality per million inhabitants, and probably it is because things has been not done in the more correct way. Probably here in March 8, excuse me, there was a lot of concentration of people, a lot of people on the streets, just on the soccer place, the football place, and the demonstration of the feminist demonstration 8th of March, that were the football plays, the demonstrations were stimulated by the government. Well, I don't go. It's not time for politics. It's time for action. The government on March 14 declared the state of alarm in the whole country and start to confine people in their houses. In the hospital, we started. We have the experience from our Italian colleagues, and we start a contingency plan just to try to deal with the pandemic, with a lot of patients that we foresee that we will have to deal. And we start. The main goal of this contingency plan was to have more beds in the hospital, to reduce the mobility of the patients, and to protect our doctors, our nurses, all our professionals. And the main tools for doing it was to reduce the surgical activity and to reduce also all the assistential activity that was not absolutely necessary for the daily care of the patients. We start a crisis committee and also an operations committee. And what it is quite important, if you look at the composition of those committees, there was a lot of people from the hospital management, medical direction, nursery direction, a lot of people from internal medicine services for the infectious diseases, for the pneumology, for endocrinology. But I think it was a big mistake at the beginning that we did. In those committees there was nobody from the surgical services, not from the general surgery service, not from urology, not from gynecology. It was a completely medical and not surgical view of the problems related with the pandemics. Our plan, the plan that we started at that time, had different pillars. The first was to protect professionals, reducing the virus exposition of the professionals by installing what we call teletrabajo, the homework. People was working at their houses. They was calling the patients by phone, trying to do as more as possible work in their houses. And also we changed our organigrams. We divide the teams in 2 or 3 different teams. People who were working at the first line or the second line, and people who were in the backstage, just waiting for going to the first line, yet trying to reduce the risk of exposition to the virus. We make an extreme increase of the capacity of the hospital. We have in the hospital, we have around 22 or 24 units for patients, and 19 of them were to COVID. We increase a lot the number of beds using, I think it is very important, beds from other hospitals, public hospitals like Hospital Plateau, but also private hospitals like Sagarco, like Clínica de Seus, like Tecnon. There are private hospitals that they put a lot of beds under our control in their buildings. Also, we start to create hospitals in hotels near the hospital. Is what we call a Hotel Salud. Is a health hotel for ill people, for people with COVID, and we increase also extremely the capacity of intensive care units. You can see here our hospital has approximately around a little bit more than 700 beds, usually, 50 beds of intensive care. And during this month, during the last month, we had more than 1,000 beds and the 3 times the number of our ECU beds. In my service, the impact has been tremendous. It is on the left side of the slide. You can see the number of visits, the number of procedures that we are performing per week at the day 0 of the pandemics. Around 600 visits per week, 50 uremic studies, 100 ultrasound studies, 60 RT procedures, including OC retrieval, embryo transfers, intrauterine insemination. But in 2 weeks, the number of beds, the number of visits, of presential visits, visits on-site visits was tremendously reduced to 15, 12, 16, no more than that figure. And a lot of visits were done by phone. We stopped completely the urodynamic studies. We only perform ultrasound for those visits that merit to go to the hospital, being mainly first visit, the first consultation for oncologic patients, and no hysteroscopy studies, no pelvic floor patients, no procedures of ART. We completely stopped our activity because the hospital was completely devoted to the COVID patients. It is the capacity of our service in number of beds during the normal life, and it is our capacity, the number of people admitted for gynecological during this month, more or less. A lot of times, a lot of days, we have no patients admitted in the hospital. We also move our personnel, the doctor who used to be on duty at the hospital. We moved that doctor to the obstetric service, to the maternity. That it is, the architectonics of our hospital is special. We have the main hospital, including the gynecology service, in a building just in the middle of the city. And maybe 3 or 4 kilometers away, we have another hospital with the maternal-fetal medicine service, with the ophthalmologic service, and also some common services like some part of radiology, some part of the lab. The most important, as you can imagine, the most important impact on the service has been on surgery. We have 10 slots on the conventional surgical area per week, 4 slots on the day case surgical area. We have 3 slots per week for office-based surgery. We are doing every day on the week oocyte retrieval, and you can see here, after the first 8-10 days of the pandemics, we have only 1 or 2 slots of surgery per week, and we devoted, obviously, those slots for oncological patients with very patients in which the prognosis was the best option at all. There's not option for any other kind of treatment, was surgery. We need to look for some solutions for our patients. We are doctors. We have to take care of the patients, and we need to, for benign surgery, for not life-threatening, for not vital indications, we need to look for another treatment. We change the indications. For example, a lot of patients with breast cancer or with ovarian cancer were changed to chemotherapy. We changed surgical procedures, trying to be as simple as we can. During these days, we are not performing lymphadenectomies, complete lymphadenectomy. We're doing just sentinel node for example, for endometrial cancer. We are doing just hysterectomy and the biopsy of the sentinel node. We also, I have to thank Dr. Figueras, because we started for a strong search for new surgical areas, and we found some small OR in the obstetric area in the maternity of our hospital, and also in other hospitals near our hospital. And these solutions, change indications, making the surgery easiest, allowed us to keep a relevant, in these circumstances, a relevant surgical activity. We managed to operate at least, maybe on average, 1.5 patients per day. I think it's quite important if we compare with other surgical area hospital that have no option to these two solutions. They use the maternity for breast cancer, and other hospitals for pelvic pathology, oncological pelvic pathology, but with easy surgeries. They have the situation on other in the urology area, in the general surgery area is critical now. We also start a new protocol on how to take care of the patient, to the surgical patient, on the emergency areas. We always consider a non-surgical alternative, and if the patient was not, the surgery was not deferrable, we try to perform a PCR and having the result in 4 hours. And if it was not possible, we always consider this patient as positive and try to treat the patient and to protect ourselves also as if the patient was positive. Obviously, you have some time to perform the test, and we can defer sometimes some hours the surgery. We try always to have the result of the PCR test, but even in case of negative results, you know that the sensitivity, you know that the sensitivity of the test that we had during the first days of the epidemic, of the pandemic here in Spain, has been very low, and we always try to treat the patient as if the patient was positive. The same for patients with not emergent surgery that was not deferrable, and we try to always to test the patient to test it has symptoms before the surgery, and if the patient has symptoms, or if the patient was positive, we try to defer the surgery. We know that the prognosis of the patient or the infected patient with COVID that we operate, or the patient that in the post-operative period become infected by the virus, the prognosis is very bad. We also was very worried about the laparoscopy. You know that the risk of it has been stated that the risk of transmission to the medical personnel from the patient in case of laparoscopy can be higher. There is not evidence for it, but it has been, it has been discussed, and sometimes in some papers has been just putting the light on the safety of the surgical team. And I agree, we need to protect the surgical team, but also we must not change our surgical route if we think that the best for the patient is the laparoscopy. We need to take the appropriate precautions, but we need to always take in mind the safety of the patient. Nowadays, it seems that it is the pink line is the situation here in Catalonia. It seems that the curve is now in a plateau. There is not the daily increase of cases is lowest during all the past month, and now it seems that the earnout is from 4 or 5 days. This slide is of today. The earnout now is below 1, so it seems that we are winning the virus. And take a look, it is the number of patients admitted in the hospital. The number in green is the number of doctors and nurses infected by the virus is decreasing. Also, the number of patients admitted in the intensive care units is not increasing. So we think that we can start to think in going back to the normal life. And also we have a special committee for doing it. And this time, you can see here, there are one surgeon, the head of the urology department, and also the head of the surgical area. We think that is quite important to include in your hospital if you arrive in a situation like ours. Please don't forget to include a surgeon on the committees. The problems with the period that we are facing now can be a lot of problems. We will have a lot of difficulties. We don't know about how the epidemics will go. We don't know if when the confination finishes and people go to the street, there is a clear risk of increasing again the infections. We know that our personnel is tired, physically and emotionally tired. Also, the motivation can be different now. The solidarity, the motivation of the people can be different. We need to be flexible and to be the measures that we take need to be parallel to the measures that the government take for the general population. And we think that an important point is to keep the critic patients, to keep the patients, the seriously ill patients in the hospital, and use the new areas that we have opened during those weeks that we passed, the beds in the hotels, the beds in private hospitals for no critic patients. Are trying to keep clean areas in the hospital. For sure, there will be during a long period of time patients, COVID patients and non-COVID patients at the same time. But we think that we need to try to get out of the hospital the COVID patients and keep in the hospital only the seriously ill patients, the critic patients. We need to divide the hospital in the COVID area and the non-COVID area, trying to increase always the size of the non-COVID area, and also we need to guarantee that the patients that will be admitted to the hospital, they are COVID negative. If there is a surgical elective surgery, we need to make the test 2 or 3 days before the patient is admitted in the hospital, and to perform this test outside of the hospital. We need to allow it's just an idea. We cannot do it in all the cases, but at maximum possible, we need to keep to permit to enter in the hospital just a patient negative for the COVID. We have a plan for surgical, for elective surgery, for emergency surgery. Very important. We need to be sure that all our professionals are negative, and we need to test them very often. We think that every 10 days, more or less, is the time that maybe per PCR, maybe serology, maybe ELISA. It will depend on the availability of the test that we will have. We don't know now, and we need to keep these preventive measures in all the areas of the hospital, not only in the medical areas, but also in the administrative, in the clean areas. We need to try to keep the hospital clean. And we are gynecologists, and we must not forget that there are a lot of things that we don't know about the disease. The disease is a very new disease, 4 months of history, this disease. And now this is a paper, this is under revision, it's under the style revision. It's a set on infertility and on sterility. And you can see they show how the ovarian tissue, the genital tissue in both males and females people has receptors for the angiotensin converting enzyme that are the cells, the domain of the proteins that the coronavirus use to bind to the cells. Also, there is a gonadotropin dependent expression of those receptors on the human ovary. So we need to be very careful when we restart. We don't know what happens with the embryos. We don't know what happens with the oocytes. We need to be very careful when we restart. When we restart the assisted reproductive technologies techniques for our patients. And also, don't forget that the virus produces a state of hypercoagulation in the patients who has the disease. And remember that we as gynecologists, we are treating patients, maybe postmenopausal patients with hormonal therapy. We are treating young patients with contraceptives, and also Mauricio, you and me are treating patients with endometriosis, and we are using drugs, estrogen hormonal drugs that may increase the thromboembolism, the risk of thromboembolia, of thrombosis in our patients. Maybe we don't know, but we need to be very careful. We have an algorithm for managing patients with hormonal treatment. Maybe when the patients are COVID positive, or maybe when they have only the suspicion. So there are a lot of things that we still don't know about the COVID, and we need to be aware of the evolution of the disease on the next, not only weeks, months, because there will be a lot of things that we need to know and to learn. Thank you very much, Mauricio, for inviting me. So I will stop my screen. Now I finished my. Okay. Now you're
yes,
not
thank you. Thank you very much, Dr. Carmona, for sharing your experience with us. And I would like to invite Dr. Francesc Figueres. But before that, I would like to say to everybody that is watching us that you can send your questions through the YouTube chat that we will be able to discuss in a few minutes. Dr. Francesc, thank you again, and we hope to listen your experience in this next 10 to 12 minutes. Thank you very much.
Well, thank you very much to you for inviting me up, for having me here, and for letting me share with you our experience with the COVID-19 epidemic crisis in relation with the obstetrical practice. As Dr. Carmona already showed, we had a sharp increase in our cases admitted to the hospital since the 15th of March, and then we reached a plateau at the end of March, and since then we have been having a stable number of patients that need admission to hospital. However, despite of this high number of cases and this high prevalence of people that require admission to the hospital, the situation regarding the during pregnancy could have been anticipated because of the experience in Italy. In Italy, they have been ahead of us a couple of 3 weeks, so their experience was highly valuable to us in order to plan our services regarding the pregnancy care. And they already told us that pregnant women are not especially vulnerable to these infections. They told us that among their thousands of cases, very few were pregnant women, and actually we had the same experience. Although in our hospital we had almost every day since the last of March, almost 1,000 of adults that were admitted, we have had very few pregnant women with a COVID symptomatic infection. During all this time, we have attended 14 pregnant women, and you can see here the frequency of their symptoms. Most of them had cough. Also, most of them had fever, and 40% of them had shortness of breath. And also a few of them, also as has already been described, have diarrhea. Because it is a respiratory virus, it does not come as a surprise that they had an increased respiratory rate with a median value of 22. Also, you can see that their lymphocyte count was increased, as it was the C-reactive protein reflecting the inflammatory state. It's remarkable that not only pregnant women, but also adults, they have an increase in transaminases, as you can see here, and as already Dr. Carmona mentioned, they had an increased hypercoagulability state that is reflected here, but an increase in the dimer D molecule. You can see here that almost 60% of women require some oxygen support, but only 2 of them require an advanced oxygen and support. And a very common finding, it's a pneumonia, and you can see that this is found in more than 40% of the cases, so it's a quite common feature. Regarding our cases, most of them, they were admitted because of respiratory symptoms, 28 of the 42 cases, and only 2 of them developed severe disease. None of them developed a critical disease. So these cases of severe disease only were cases that were transferred to a specific area for advanced oxygen support, but none of them require intubation. In addition to these 28 respiratory cases, we had 14 cases that were admitted for several obstetrical reasons, most of them for delivery. And you can see that few of them, only 4 were asymptomatic at admission, but 10 of them were symptomatic, only mild symptoms, and they remained as mild cases throughout their stay in our hospital. You can see that we perform 40% of cesarean sections. We didn't find an increased risk of SGA above what is expected. That is at 10%. We only found 5% of SGA of small for gestational age babies, and we didn't find any case of preterm delivery. This mild disease in pregnant women has already been reported in other series, and this is the summary of all the series, the 16 studies that have been published, comprising more than 200 women. And you can see that overall the proportion of complications is very low, only 12% of preterm deliveries, very few cases of maternal severity with no reported death in the literature. There is some report in the media, but not in the literature, and very few cases of neonatal infection that are horizontal cases, not vertical transmission, because this vertical transmission has not been demonstrated for this virus. And we had very few, there are very few cases of reported neonatal death. So as a summary of the clinical presentation, pregnant women have a very low prevalence of symptomatic infection because they are young, and probably because their immune state is protective against this disease. And also they not only have mild symptoms, but they also have very few rates of pregnancy complications. From a point of view of the organization, the first thing to do when you have to prepare to face this crisis, this epidemic, is to define within your hospital, within your department, clean areas and soiled areas. So clean areas and contaminated areas. These two areas should be as separate as possible to avoid transmission of the disease. And these contaminated areas should include waiting rooms for patients and for their accompanying people, examination boxes, delivery rooms, surgical theaters if you have to perform a cesarean section, and also hospitalization ward, especially for these women and these neonates. These are contaminated areas that should be separated from the clean areas. Also, from an organizational point of view, it's very important to organize your staff, your personnel. And the first thing you have to do is to define shift in order to segment the risk of exposition. And within each shift, it would be ideal to define special people to attend women with COVID. So you even reduced more the risk of exposition by doing this strategy. And also it's a good strategy that we have started now, as Dr. Carmona mentioned, to consider universal staff screening with PCR or serology if available. And we have now started to do it during this week. A very also important thing to do is at admission to make a first triage of symptoms in order to define which women should go to the soiled area and which one should go to the clean area. And we have done it by running this checklist at admission to the hospital, where women and their accompanying people are asked for a few questions regarding symptoms of COVID. And if all of the symptoms are absent, then the attendance is performed in the clean area. And whenever one of the symptoms is positive, then we provide them with surgical masks. We then call the doctor and the nurse to perform the first evaluation. The first evaluation could be performed using the interphone, so to avoid any unnecessary evaluation. And in some cases, after this first evaluation, the risk is ruled out, and then in that case, the woman is treated in the in the clean area. And when this risk is confirmed, then a full clinical evaluation is performed, including a swab of an nasopharyngeal swab to test for COVID, among other viruses, and also different examinations are then performed in this woman. I'm not going to go in detail on how we manage these cases. The only thing I want you to take is that at hospital evaluation, we then perform another checklist to decide whether it's a mild case that could be treated by home isolation, or it's a more severe case that needs admission. And you can see that the criteria for admission, it's any of these criteria here: persistent fever, criteria for pneumonia, the presence of any comorbidity, and also when there is a curve score severity above 0. The curve score severity is a score for pneumonia severity, and whenever there is confusion, an increase in the urea levels, a respiratory rate above 30, or a decreased blood pressure, if any of this is present, then admission is required and proper treatment then is given to these women. Women with criteria that require admission are at hospital for about 1 to 2 weeks, and as I already mentioned to you, they are kept in a specific contaminated ward where they are attended. So, as I already mentioned to you, in about 1/3 of our cases, the woman had a delivery, and so they should be attended in the delivery room. And already, as I mentioned to you, we have dedicated a special area and a special delivery room for attending these women. As a general concepts, you have to keep isolation during the whole delivery process. You have tried to minimize the number of people with the delivering woman. Ideally, nobody should be there, but in the last 2 weeks, we have been allowing one accompanying person to be with the delivering woman, and that support person is kept within the same delivery room with a surgical mask and keeping a distance with the woman. And also we have tried to minimize the number of vomiters, that is the objects that could be a vector for the infection. So we have eliminated fetal heart rate strips. We have eliminated neonatal footprints, any document, any paper that can be produced inside the delivery room is potentially contaminated. So we have avoided any most of this material. It is important that COVID infection is not an indication for labor induction, and is not an indication to perform a cesarean section in clinically stable woman. That, as already told to you, it is the case in the vast majority of cases. Very few women have a severe illness. And during labor, we have been performing continuous CTG because it has been reported a risk of fetal distress, although more recent series have found that this risk is not much increased. It's very important to protect professionals against infection by using adequate protective equipment. The adequate protective equipment for attending labor comprises disposable goggles, or also alternatively a full-face visor, as you can see here. It's also important to use a mask that has a high filtering efficiency, and for delivery, it recommended an FP2 that it's equivalent to the N95 in America mask, or an FP3. In cases of a vaginal examination and other procedures that require not a direct interaction with the woman, then a surgical mask or an FP2 would be enough. Also, it required a gown, double gloves, and a waterproof apron to attend delivery. It's very important to keep your professionals attended, but because one of the problems is that the proportion of professionals that are infected could be very high. In our experience in our department, it has been very, very low indeed, probably because of this protection. But for other professionals in the hospital, in some services, 5-10% of their professionals have been infected, and that's a problem when you have to organize clinical practice. And so it's a good thing to do to protect your professionals. Well, after labor, the ideal painkiller is paracetamol because non-steroidal anti-inflammatory drugs are contraindicated because there are reports that they can speed up the disease. We have been allowing skin-to-skin contact between the mother and the baby, and also rooming in the mother and the baby. And following the WHO recommendations, we have been promoting breastfeeding for this woman, keeping isolation measures. In women with mild symptoms and early discharge, it's reasonable. It's a good practice, and also it's a good practice to perform follow-up by phone or by any other telehealth media that we can use. It's important to note also that the coronavirus crisis has had an impact in our service, not only because of the need to attend women with suspected or confirmed COVID, because we have had to adapt our pregnancy care in order to minimize the risk of infection to women, and we have done it by restricting the number of visitors. In most of our examinations, we are advising women to come to the hospital alone without visitors. We have performed a screening for symptoms, not only at hospital admission, but also at box entry, before box entry, because we have seen in some cases that some women and also visitors with minor symptoms are not captured at admission, and it's a good idea to repeat the screening several times. We have provided patients with surgical masks in the last weeks, and for professionals now we are recommending when performing an examination at least an FFP2 at least. It's also important a hand washing policy between examinations, and also a surface cleaning after each visit. And probably the most important thing that we have done to adapt to this new situation is to convert to telehealth as many visits as possible to reduce in-person visits to the hospital, and thus minimizing the risk of infections. Another good thing to do is to time and to group visits and tests. So we try to combine several tests and visits each time woman has to come to the hospital to avoid unnecessary and repeated visits to the hospital. Well, because in our area, some small maternities closed down because their hospitals went into complete COVID hospitals, and they have referred their deliveries to other referral centers, and that's why we have increased 20% the number of our deliveries, and we adapt to this situation by slightly increasing our staff in the delivery room. One of the gynecologists that are working in the reproduction area went to the hospital and thus helped us in attending this increased number of deliveries. The main thing to do is to move to telehealth, and our experience is that more than 50% of the visits during pregnancy could be done by phone or by using any other media such as Zoom or the one that we are using now. It's also important to minimize tests, and here you can see some examples of things that we have stopped to do. For instance, we have stopped to retest a woman with symptomatic bacteriuria or a contaminated urine culture. We have stopped giving anti-rhesus to negative women at 28 weeks. We have tried to use a glucose tolerance test that minimize the time in hospital, that it's the 75 glucose challenge test instead of the 100 glucose challenge test that takes almost 4 hours. And we have not made any special visit to perform a GPS screening, and if unknown, we have managed these women as unknown according to the local protocol. Also, we have avoided to perform non-stress testing in women at low risk. And again, also, as Dr. Carmona mentioned, in the last 2 weeks, we started to screen for symptoms, and in the last days, to screen using a PCR all women that had an elective cesarean section or a labor induction, so 28 hours before hospital admissions, they now are tested for COVID before admission. And we have preferred induction methods that are more efficient, so to minimize the time in hospital, and all our postpartum follow-up has been made in the last 3 weeks by phone. Also, we have defined some ultrasound examinations that should be performed now. Some of them that could be performed in a couple or 3 weeks, so trying to defer them in time, and other ultrasound examinations that could be directly suspended, so no need to do third trimester ultrasound in low-risk population. And that's it, and that's how we adapted to this situation. And as a summary, I would like to conclude by saying that COVID-19 has a low impact in pregnancy, mainly because pregnant women, by definition, are young women, and the disease in young people is much milder. There is no evidence of vertical transmission, and there is no evidence of worsened prenatal outcomes in women with COVID infection. And probably the main challenge for obstetrical departments during this COVID-19 crisis is to adapt in 2 directions. The first direction is to be able
I think that the connection
has been lost.
Yes, Figueira is poor. While he reconnects, I think that he was already finished his presentation. Yes. Very nice presentation. I'd like to thank a lot both of you. We know that it's very late in Barcelona. It's 1 p.m. in Barcelona. So while he comes back for his Mauricio. Is there? It's 1 a.m., right?
No.
I know.
Yes, 1 a.m., yes.
Just 2 questions again. João.
Yes, we have several questions here. One of them is in relation to if you see is there any evidence that coronavirus viability in bodily fluids like urine or blood or feces, and for example, if the virus can be transmitted through a needle stick or the contamination of the team? This is one of the questions that we have here. Dr. Carmona?
We have some evidence of the ability of the virus in some corporal fluids, but and also there is some evidence, some data suggesting, but we have no strong evidence of possible oral transmission, fecal oral transmission, and the risk for the surgical team are related with the aerial transmission. There is not the main way of transmission is by air, by the nose, by the respiration, and it is the most important thing to protect. During laparoscopy, you know that some aerosols can be formed, and maybe it has been suggested that the risk can be higher that in open surgery, but there is no evidence about that. You remember that it has been the same with other viruses like hepatitis or human papillomavirus, but there is no evidence. We are doing laparoscopies for more than 50 years, millions of laparoscopies all over the world during that time, and we have no evidence of transmission of maybe some anecdotal cases, but there are not. Maybe with the coronavirus can be different, but by the moment we need to keep in mind that which is the best way for the patient, and if the laparoscopy is indicated, we need to do the surgery by the best route that we think.
Okay, Dr. Figueiras is back. Do you have your close remarks, please?
Yeah, but before that, let me ask you if you could see my presentation.
Yes, very well.
All right, okay, because when I finished it, I found you frozen, and I was not sure whether you could follow it or I had been speaking for myself. That's fine.
No, so, until then.
Right.
It was in your
my closing remarks is that, as I already said, low impact in pregnant women could be expected because they are young, and the main challenge is to organize yourself to attend these few women that can contaminate your whole department by separating areas to attend women without symptoms and women with symptoms. And this should include the whole process, so an examination box, a delivery room, and also a hospitalization ward. And also the other challenge is to adapt to attend to an increase in the number of deliveries because of referrals from other centers that have to close to convert into COVID hospitals, and that has been the case in our city.
Okay, we have another question here. If has anybody at Barcelona thought of home delivery instead of hospital delivery for non-symptomatic pregnant women, especially multiparous with previous normal deliveries?
Well, not in Barcelona, but to me it's a clever thing to do if you are in a setting where home deliveries are well organized, which is not our case in Barcelona. But for instance, the Royal College in the UK, it's advocating for home deliveries. Also, the ACOG also advocates for home delivery. the best thing you can do to protect women is to avoid them to come to the hospital. So if you can provide a safe environment for home delivery, that would be an option. It has not been done in our city because that's something that is done by a very small minority of women, home delivery in our country, but in other settings where it's a far more common thing to do, I think it's a clever thing.
Okay.
Great. Mauricio.
Yes. Just to finalize, it's 8 o'clock here in 8 p.m. in Brazil and 1 a.m. in Barcelona. I would hear from both of you, first Professor Carmona and then Professor Figueiras, the message that you can leave for us in Brazil in this moment that our curve is raising, hopefully not that much as it raised in Spain, but what's your final message from there? Paco, please.
I think that you must try to keep your curve below the Spanish curve, and for that the best option is to increase the social distance, to try to keep clean areas in the hospitals, to evit as much as possible, as Dr. Figueras told before, that the patients, the people go to the hospitals, because the hospitals are the main focus of infection, one of the main focus of infection. For the surgical cases, remember that in that moment, the surgery can be a very risk factor for people who are infected, and you need to be very careful when indicating the surgery. Try to do only the surgery that real needed by the patient.
Yeah, and my last advice for you would be to gather as much protective material you can. Now that you are starting with your cure, you may still have a good provision of this protective material, but whenever the cure rises, you will experience shortages of this material. So it's time now for you to gather as much surgical mask you can, as much respirators you can, as much waterproof aprons, as many gloves you can, because that's something that in the peak of the epidemic cure, it's something that you are going to need to protect your professionals. Professionals, it's a high vulnerable segment of people, and they are key in keeping the hospitals working, and they should be a special object for protection.
Thank you so much. We have some other questions, but unfortunately, it's too late for us to answer. So if we can, we are trying to answer those questions by email or by WhatsApp. If you guys answered questions and we didn't answer, please provide us your information, your WhatsApp or your email for us to make it happen. So again, I would like to thank you a lot to be with us here. I know the efforts that you made to make it happen. I'd like to thank João Silfi to help me with this presentation here, coordinating all of this. I think that, can you see my screen, João?
No, we're not seeing your screen.
Okay, so, and just to conclude, I'd like to invite you to be with us next week. We are going to be here at the same time, and the topic that we are going to present is this topic here: integrative medicine and modern women's in this time of the COVID-19. That is very important for us to use other alternatives, right? That is very important. And I also would like to invite you to attend this webinar tomorrow. That is the webinar of AGL. It's going to happen at noon EST, Standard Eastern Time, in the US. It will be 1 p.m. here, and I think that 6 p.m. in Spain. So we are going to discuss a multi-specialist approach to COVID-19, that it's a very important initiative. So I'd like to thank you a lot, and hope to see you soon. And this webinar was recorded, and it will be in our channel, YouTube channel, with subtitles tomorrow. Okay, thank you so much.
Okay,
Thank you.
Thanks.
Thank you. Stay safe.
Bye.
Have a good day. Bye.
Bye.
Take care.
The host has left the conference. The conference is about to end.